So thank you very much, Gabriel, for the introduction. Hello, everyone. Also from my side, I'm Tina. I have done a lot of research related to multiple myeloma and preclinical animal models and imaging, and I have especially found DEXA to be really useful in those studies. So I am really excited to give this talk to you today. So without further ado, let's get started with today's topic. So I have divided today's presentation into 5 different parts. We will start by giving an introduction to multiple myeloma and multiple myeloma bone disease. I will also walk you through some working group recommendation in regards of treatment and imaging of bone disease. Then we will head to introduction to preclinical imaging and especially DEXA technology, which is our one of the key aspects to discuss today, giving you some background and examples. Then we will do introduction to multiple myeloma animal models, give some general techniques and considerations, and then we will be spending some time to go through some case examples from multiple myeloma studies, covering a variety of studies related to studying bone effects and also multiple myeloma targeting drugs. We will end up today's webinar by doing a comparison on preclinical and clinical finding, and I will provide you a summary of DEXA use in multiple myeloma. So in the image on the right-hand side, you can already see that some of them point out to our main topic today, which is the bone. So bone is actually a really important aspect in multiple myeloma, and you will hear more about this today. Let's start by discussing what is multiple myeloma, because I'm not sure that what is everyone's background, so I want to make sure that we are aligned on some key aspects of this disease. So multiple myeloma is a hematological cancer, a plasma cell malignancy. So plasma cells are white blood cells that reside in bone marrow, and their primary function is to fight diseases and make antibodies. So in the image on the right, you can see the normal bone marrow, the plasma cells there, and some antibodies that they produce. In multiple myeloma, these cells start to multiply, so they proliferate actively, and they also start to make these kind of abnormal antibodies and a protein called M protein, and we will come back to this M protein multiple times during the presentation today. So as multiple myeloma is a disease originating from the bone marrow, it also has many harmful effects on the bone, but it also affects other organs like kidneys and, for example, blood, especially in the sense that the multiple myeloma in the bone marrow actually prevents the normal production of red blood cells, and this leads to anemia and tiredness, which is one of the symptoms behind multiple myeloma. In the image on the right, you can see a classical multiple myeloma patient journey, and here we get back to the M protein that I mentioned to you earlier. So the disease is defined by measuring the M protein amounts in the patients, and usually patients have a precondition stated as MGUS over here. So when the M protein levels start to elevate in the patient, they develop active multiple myeloma, and this is also the time point that they get their first-line therapy, which reduces the M protein levels, and patient head to remission. Unfortunately, it happens often that the remission is not permanent, so then the patients do relapse, so the M protein levels start to go up again, and then they receive their second-line therapy, which can then decrease the protein levels to some extent. Usually there is another relapse later on, and this starts to be the time point that the treatments start to be really ineffective. And actually what you can see here at the end of this graph is that we are far from cure in multiple myeloma patients. So it is unfortunately incurable at the moment, so definitely one area where we need those novel treatments. So when multiple myeloma is incurable, the main cause for the current treatment is to try to control tumor growth, to make the disease progress as slowly as possible, and also avoiding infections and kidney damage that I mentioned earlier. and also alleviating symptoms like tiredness and bone pain. And actually, bone pain is something that is really common for multiple myeloma patients, and it is one of the key factors that is decreasing the quality of life. So this is something that we currently have some treatment options available, but they could be more effective as well. So I will next give you a short summary on multiple myeloma treatment options currently. So the current treatment options include, for example, proteasome blockers, proteasome inhibitors. One of the most commonly known is called bortezomib. So these are drugs that actually inhibit the proteasome function in the cells. So this leads into accumulation of proteins in the cells, finally leading to multiple myeloma cell death. Other agents that are given are for example, different immunomodulatory drugs. Maybe lenalidomide is the most commonly known, and this is one of the drugs that helps immune cells to find cancers. A couple of years ago, I believe it was in 2015, when CD38 targeting drugs were approved by the FDA. So this is one of the newer class of drugs that we have currently available for these patients. And the first drug that was approved is called daratumumab. So this is a drug class that helps the immune cells system specifically to attack and kill multiple myeloma cells. Other treatment options include, for example, steroids like dexamethasone and prednisone, which mainly help the inflammation compartment. And then there are some chemotherapy drugs, but they are not so often given to multiple myeloma patients, or if they are given, they are usually given in different kind of combinations. For example, in combination with bortezomib and dexamethasone, as mentioned here in the slides. And for example, in the case that the patients do receive a stem cell transplantation. The last class of drugs that is highlighted in orange in the presentation here is the bone strengthening drug. So as mentioned earlier, multiple myeloma has a really strong connection to bone, and it actually increases a really increased and tremendous bone loss in the patients, and that's why many of those patients do need to get this kind of a bone strengthening drugs, zoledronic acid being one of them. And in the next slides, we will be talking about this problem in more detail. So let's start by explaining what is a multiple myeloma bone disease and what are the causes behind it. So normal bone homeostasis is really about a balance between the bone-forming osteoblastic cells and bone-resorbing osteoclastic cells. So when these cells are active in the same level, so then the bone mass is maintained. What then happens in multiple myeloma is that these cells secrete different factors that are able to promote the osteoblasts. The osteoblasts then produce actively or more a substance called a rank ligand. And this rank ligand, it then binds to a rank receptor, which is then located in the osteoclast bone resorbing cells. And this rank-rankle pathway is actually one of the most commonly acknowledged and the strongest activator of bone resorption. When this and the binding to the rank receptor actually leads to increased activity of the osteoclast, so there is more bone resorption happening compared to the amount of new bone that would be formed, leading to the fact that the bone mass is being decreased in the patients. Moreover, I'm not sure if it's familiar for many, but bone is actually a great reservoir of different kind of growth factors, for example. And when the bone is being resorbed by the osteoclastic cells, all these growth factors are being released, and then they can be uptaken by the multiple myeloma cells, which then start this loop again. So this loop here is usually referred as a vicious cycle. So this happens in multiple myeloma, but for example, in bone metastases and other diseases where cancer and bone are in interactions with each other. As mentioned about the drugs, so there are some ways that we can inhibit the osteoclastic activity to try to maintain this bone mass and prevent bone loss. So the bisphosphonates, the zoledronic acid, as mentioned earlier, is one of those drugs, but then we also have other alternatives like denosumab available. So the choice is usually for multiple myeloma patients between these two drugs. So everything now described that how this works in cellular levels, but what does it mean in the patient lives and what does it mean in practice to their bones? So that is presented in the figures on the right. So here you can actually see an image of, so this is from a mouse tibia. So this is reflecting a healthy bone. You can see that it is intact, quite stable in the surface. And then next to it, you can see example from a multiple myeloma mouse model. And you can probably acknowledge that their bones are actually looking quite different from each other. So in this case, you can see this kind of holes in the cortex of the tibia. So this is reflecting really an end stage multiple myeloma in mice. In human, we can actually see the same kind of phenomenon. So here in the skull of this patient, you can see this kind of a darker spots here and there. So these are all sites where the cancer has increased this bone resorptive activity and has led to decreased bone volume. The last example is there on the right. So in the arm of this patient, you can also see these spots. And when I get asked that what do the bones in multiple myeloma look like, I say that they look a bit like cheese. And you can probably, by this example, understand that how painful this can actually be, and that this phenomenon all leads to high risk of fracture and really a devastating bone pain. Multiple myeloma working group has given some recommendation in regards of treatment and imaging in multiple myeloma. And in regards of treatments, the zoledronic acid, so the drug that I mentioned already earlier, is then the preferred bone-targeted agent for patients with multiple myeloma. And it is recommended that it would be given to patients with newly diagnosed multiple myeloma, either with or without bone-related disease. So in principle, everyone who has multiple myeloma will develop bone disease as their disease progresses. So it is really important to protect their bones really early on so that we would be avoiding the situations and examples that you did see in the previous slide. The working group also acknowledges that the the detection of bone and bone marrow lesion is really important, and it is needed to provide prognosis, also in regards of treatment planning, start and follow up of the treatment responses. In regards of what imaging methods to use, then usually the whole body CT is the advised choice, and that is based on that is usually available in all cancer centers, but they also acknowledge that there could be more specific imaging methods available to study and to understand the bone effect in these multiple myeloma patients. So from imaging, we went ahead to a different type of imaging method, which is one of the topics of today's webinar. And this imaging method is dual energy X-ray absorptiometry, so DEXA as a short. So if you're not aware or familiar with DEXA earlier, so it is a technique that uses two different energy level X-rays, so basically high and low, and then it's able to estimate the bone density and amount of soft and lean, soft and adipose tissue in the body. And DEXA is especially a known method that it has been this gold standard method for diagnosing osteoporosis, so a bone loss disease as well, and that's why it's also applicable for multiple myeloma. So if we think about the clinical and preclinical application mentioned here in the bottom of the slide, then in the clinics we are using DEXA to study the bone mineral density, so BMD, for the timely diagnosis of metabolic bone diseases. And basically in the preclinical devices we can do the same, but also analyze the body composition simultaneously in different research animals. So DEXA has also applications beyond the BMD measurements where it was originally invented. In the questions that we received before the webinar, there was a question about where can DEXA be used. So this is one list to try to answer that question. So DEXA can actually be used in multiple different indications and areas. So if we look here on the bone disease side, it can be used to study osteoporosis, as mentioned earlier. But for example, rare bone diseases like osteogenesis imperfecta, which has this kind of really fragile bone, so it is also a very delicate technique to study these kind of conditions. You can use to study, for example, bone fractures and fracture healing. There's a lot of implications in the dental field. And one of the, if we think about the body composition analysis side, so analysis of the lean and fat mass, then one of the most common fields is to use it in diabetes and obesity related research. Today we will be talking about the last part in this section, so the cancer implications. And today I will be giving you examples on multiple myeloma and multiple myeloma bone diseases especially. But if you are, for example, working with a primary bone cancer called osteosarcoma or bone metastases, then actually a lot of techniques and tips are straightly applicable for those indications as well. Some of the questions that we received earlier were also related to what can you actually then get out of DEXA. So this is a table quickly summarizing that. So in the bone aspect, we can get the bone mineral density and bone mineral content. As mentioned, we can also measure the fat amount of fat or adipose tissue and also lean mass. One of the biggest advantages of DEXA for me personally is that we can actually see what's happening in the mouse. So here in the right, you can see an example image of the X-ray image of the animal. And with DEXA, you can actually get all these parameters that are listed in the list for the whole mouse level. But you can actually then, on top of that, do a specific ROI-based analysis and, for example, here decide on which bones you would like to study specifically. So this is one of the highlights of these methods for me especially. If we think about in a broader level that what are the benefits of DEXA for multiple myeloma research, then I have listed here 4 of my favorite topics. So first would be the multiple imaging per animal. So that actually provides you one way to study how the disease progresses in animals. So you can do multiple imaging during the study, and the imaging itself is actually quite quick and easy to perform. The second important issue mentioned here is then monitoring the bone loss compared to baseline. So meaning that before these animals have developed tumors. And if you have worked with bones or bone models before, you can probably acknowledge that there's a lot of variation between the individual mice, and by doing this kind of a baseline measurement you can actually then compare that how is the disease progressing, for example, in all individual animals, and that can be used then to minimize the variability of those findings. The third one mentioned here is then the efficient analysis of multiple bones, and especially this ROI-based analysis that I mentioned earlier. So if we are thinking about more laborious technique, let's take micro-CD as an example, then usually that is very laborious, time-consuming to do, and you will have to focus on, for example, just one bone. But here, when you can actually select many bones and do, for example, analysis on all long bones in the animals, and it only takes you maybe a minute maximum. So it's very easy to do, and you can also go back in the data and do that later, so you don't have to before starting the study to decide that what will be the most interesting bone for your specific case. The last part here, so number 4, is going a bit outside of the bone field, but it is really important as well. So with DEXA, you can actually efficiently also study cachexia, so that is a wasting syndrome. And if the time allows, I have some examples to show about cachexia as well. So let's see how we manage with time when we get towards the end of the webinar. But to mention here, so cachexia is really abundant in many of the multiple myeloma animal models. So that is the reason that I wanted to bring it out already here. So at this point, we will take a short break, and I will hand it to Gabriel to take over the audience poll.
Thank you, Tina, and thank you for the presentation so far. As Tina mentioned, we're going to take a brief moment to launch a quick poll for the audience, and the questions are going to be the following. So, the first question is, what kind of modality do you use in your current studies? With the options being MRI, PET, in vivo micro CT, ex vivo micro CT, ultrasound, optical imaging, SPECT, or DEXA. So, and the next question is, if you have experience with DEXA, what system have you used? So we're going to take a brief moment. And while you guys are taking the poll, I would also like to make a quick announcement. So Scintica will be attending the Orthopedic Research Society annual meeting, where you'll have the opportunity to speak with us about your research and learn more about our DEXA system. This year, Dr. Jane Marrow will be presenting a talk titled Quantifying and Visualizing Bone, Integrating DEXA and Micro CT in Preclinical Orthopedics. The presentation will highlight the use of in vivo DEXA and ex vivo micro CT as a complementary imaging techniques for preclinical bone research. So this is going to happen on March 29th at 10:35 a.m. So please feel free to stop by our booth and talk about your research, or if you have any questions, we're always more than happy to address them. So we're just going to give a couple brief seconds for everyone to answer the poll, and we're going to be continuing with Tina's presentation. I also want to remind everyone that if you have any questions during this session, please feel free to use the Q&A section, and we're going to be addressing them at the end of the presentation. So we're just going to take a couple more seconds, and we're gonna continue presentation. Okay, I'm gonna end the poll, and I will now hand over the presentation back to Tina.
Thank
Thank
you.
you, everyone.
Okay, so then we are going to switch to a bit of different topic to start with, and we will start by discussing the multiple myeloma animal models. I wanted to start this part by giving you a reference of a paper mentioned here in the bottom. So this is a really useful sort of a technical guideline or manual if you are considering starting to work with multiple myeloma animal models. So this will give you sort of a protocol level overview of what you should be doing and for what reasons. So this paper will actually describe you the different model system mentioned here. So how induce a multiple myeloma models in the animal. So for there you have a few choices. The first choice here is to use a tail vein injection. So this is the injection of multiple myeloma cells into the tail vein. So then they would be going to naturally circulate with the blood flow, and this is considered as an orthotopic model for multiple myeloma. If you want to study specifically the effects of multiple myeloma bone disease, so then one choice would be to go for intratibial injection of cancer cells. So this means that you will inject those multiple myeloma cells into the tibia bone marrow. And this way you will have sort of a condensed tumor and really robust bone effects reflecting the active multiple myeloma bone disease. The last choice in the list here is then the subcutaneous injection, so injection of cancer cells under the skin. And this is not my favorite of these three different model systems in regards of multiple myeloma, for the reason that if you do it this way, you are actually forcing that hematological cancer to grow like a solid tumor. So it may have some consequences in regards of cancer biology and also in response to therapies as well. So the first two would be my recommendation from the list. In regards of imaging, this paper highlights the use of either fluorescence or bioluminescence imaging, and the choice of method depends on what kind of cancer cells are you using. So if they have a fluorescent tag, then you can do a fluorescent imaging. If they have been transfected with luciferin, then you can go with the bioluminescence imaging. The last choice here is for the MRI, and these methods are basically just to see that how the tumor is growing in the animals, not giving content on what's happening to the bone. This list does not include the use of DEXA because that's not the method that the authors were using by the time that they were making this review paper, but I would definitely personally add DEXA to this list, and hopefully by the end of this today's webinar you would come to the same conclusion with me. In regards of ex vivo analysis, you can do ELISA. So, for example, measure this M protein or paraprotein, which is the counterpart in animals, to assess the tumor burden. And on the bone side, you can, for example, do micro-CT imaging and bone histomorphometry and histology. Here in the table 1, you can see an example of different multiple myeloma cells that are being used in different kind of animal models. And here in the top, I wanted to provide you an additional advice or reference to a paper where some use of some of these cell lines has actually been described in more detail. So even though the title of the presentation is called Animal Models of Bone Metastases, the multiple myeloma bone disease is very similar to bone metastases, so that's why I actually provide also some insights to multiple myeloma models as well. So this is a really useful review article on this front. In earlier today in the presentation, I did give you some ideas of what is the multiple myeloma bone disease looking like in humans. So here we'll do a quick comparison to animal models before we head to the case example studies that I would like to discuss with you today. So if you remember, there was a X-ray image of the skull and then also from the forearm, having this kind of hole-like structures in the bones. So we can appreciate that the same type of phenomenon really happens here on the mouse level as well. Previously, you did see an example or micro-CT example from mouse tibia showing that what's happening to the cortical bone. And here we can take a look on inside that what's actually happening inside the bone. So a image is from a healthy mouse. So you can see that the cortical bone over here is intact. And we can also see that there's a lot of trabecular bone over here. So this is a normal situation in a healthy mouse. In a mouse with multiple myeloma bone disease, we actually do not see that trabecular bone basically anymore. And we can also see that the cortical bone is a lot thinner here on the edges, and we can already see some kind of holes here throughout the bone. So the bone structure really changes dramatically as the disease progresses. Lastly, let's have a quick look on the histology side, because that was also mentioned as one of the analysis methods in the previous slide. So this is a Goldner Trick-Rowe staining of the femur in this case, and we can see here again the intact cortical bone and some trabecular bone here in the below the growth plate in the normal animal, and here in the multiple myeloma animal with a multiple myeloma bone disease, we can see again those holes in the cortical bone, and actually we do not see any trabecular bone or very little of them remaining in the animal models. So this slide is to tell that the disease is really similar in humans and in animals when we are discussing the multiple myeloma induced bone disease. I wanted to give you an example of another publication, which is titled An Improved Animal Model of Multiple Myeloma Bone Disease. So in this study, they actually used the same tumor cell line named 5-TGM1, and then they injected them into two different mouse strains to see that how the disease develops in different animals. So they were using an immune deficient NSG mice, and then they were using a specific mouse strain called Galvich. And these Galvich mice are peculiar in a sense that this is actually the mouse strain where this 5-TGM1 cell line originates from. So this was a so-called syngeneic mouse model that they did. They induced the disease by injecting these cancer cells via the tail vein, and then they monitored the progression of the disease by measuring the serum paraprotein level. So this is basically the same readout than in humans when we are measuring the M protein that I mentioned earlier. From the graph A, you can see that when you inject these cancer cells into the NSG mice, so the immunodeficient mice, you can actually get a higher tumor burden, and you can also monitor the animal for longer than if you are injecting the cells into the Galvich immune competent mice. We do also see a difference when we are using DEXA and looking at the bone mineral density between these mouse strains. So the black bar here is presenting a control condition. So this means the bone mineral density in animals without multiple myeloma. And when they have multiple myeloma, then we can see that bone mineral density goes down. So they do have this myeloma-induced bone loss happening similarly to the human situation as well. So this is from the Galvich mice, and then when they do the same comparison in the immunodeficient NSG mice, they can see the same phenomenon, but the bone loss is actually more profound compared to the other mouse strain. They wanted to clarify this even further, and they did bone histomorphometry analysis. And in principle, the finding is the same. So they can see the decreased bone volume in the Galvich mice here, and also then the trabecular thickness goes down. But those effects are again more profound when they are using the NSG mouse model. But here we do not see that. Do not know for sure that if this is completely related to the mouse strain or due to the fact that they were able to monitor the tumor growth for a longer time in this specific mouse strain. But this is a good example to show also in the case that it is really important to understand and know what kind of mice you are using in the studies, because they have a lot of differences, for example, in their bone content as a default. So it's good to understand what kind of mouse strains you are using and for what purpose. Next, we will head to the case examples from multiple myeloma studies. I have selected here 3 different case examples to go through with you. So we will have an overview of the animal model, preclinical imaging, analysis techniques, and results as well. And then I will give you some ideas how I would see that DEXA could have benefited the research even more than the data presented in the slides suggest. So let's move forward to the first case example here. So this is an example from multiple myeloma bone loss. So here they did use this 5T2mm multiple myeloma cell lines and injected them into the culprit mice, so similarly as in the last example. Tumor growth was again monitored by paraprotein levels, and when the mice did develop an active disease, they were treated with recombinant human FCOPG31, and the study length was overall 4 weeks. In the figure A, we can again see the already maybe we can say a typical case example from mice. So we can see this kind of holes in the bone. So we can see that these mice actually did develop a really active multiple myeloma bone disease. On panel B, we can see X-ray examples of the extracted bone. So here the first bone is reflecting a healthy bone. The second one is the one injected with multiple myeloma cells, but the mice were receiving a vehicle treatment. And then the number C is the one where the mice did receive the multiple myeloma cells, but got this OPG treatment. The white arrows here point out the individual bone lesions that were observed, and actually we do see them a lot in the vehicle-treated mice, but not so much in the OPG-treated mice. This was quantified by actually counting the number of lesions that they observed in the bone. And here in the control conditions, without any tumor cells, we do not see any lesions. But with the vehicle-treated mice, we do see a lot of them. And in the treated animals, the number of bone lesions goes down. So that actually goes quite nicely with the case examples of X-ray images presented here. In this study, they also did use DEXA to analyze the bone mineral density again. So this is from the control animals without any tumors. So this is sort of a reflecting normal bone mineral density in the animal. And here in the animals that did receive vehicle treatment with the cancer cells, we can see how the bone mineral density goes down. But surprisingly, with the OPG treatment, we can actually see that the bone mineral density goes up, and it goes to even higher level compared to what is observed in the normal control animals. So my suggestion for the study would be to include also ex vivo analysis, because the one that they present here in this paper include also ex vivo analysis of one specific bone. So it would have been really nice to see that how these changes are then, or if the changes are also observed in vivo, and to give sort of a dynamics that how this increased bone mineral density in the OPG-treated mice develops, and that would be possible to do with the DEXA method that we have been discussing today. The second example is to study the local and systemic bone effects. So this is again a bit different animal model that they used here. So they actually did obtain the multiple myeloma cells from bone marrow aspirates from 11 multiple myeloma patients. And they also did use this kind of a specific bone graft, of which examples you can see in the panel B. So they were actually using a pieces of a rabbit bone injected with multiple myeloma cells, and those were then placed in the under the skin of the animals. They did also measure the tumor burden in this specific model, and here they used a anti-human DKK1 neutralizing antibody and control antibody to see that what is happening to the myeloma bone and also to the sort of healthy bone in this case. But let's go through the results here. So the in the figure 1A, they actually did perform a comparison between the baseline and the end measurements. So that's why they are able to provide the change of BMD. So the BMD in the control animal went down. So we could see that there is some active bone resorption happening in the animal, and with the DKK antibody, they could actually see that the bone mass is increased above the baseline. We can also see this happening in the X-ray images provided here. So this is the control without the treatment, and here the arrows point your attention to the sites of active bone resorption, and whereas in the DKK antibody treated animals we can see the widening here in the example, so that reflects a newly formed bone. So this treatment seems to be actively promoting bone formation. Again, with DEXA, they did also check that in non-multiple myeloma containing bones. So this was done in the femur of the animal. So they can also see that it is happening regardless of if the bone had a myeloma in it, or if it was an intact or we could say healthy bone in this specific case. It was observed in the femur of the animal, and they also did the same comparison in this bone graft which did not have the multiple myeloma cells in it. So it really seems to be a specific bone effect, not just caused by multiple myeloma disturbing the normal bone homeostasis. Here I would also suggest that the researcher would have done a longitudinal in vivo imaging, so it would have again be nice to see this kind of a dynamic changes in the bone. And with the DEXA technique they could have actually have the whole mouse image and then just selected multiple ROIs there and done the bone analysis from multiple bones quite easily. Let's move forward to the third example, which is then a multiple myeloma tumor and bone effects. So in this study, they were using basically the same kind of approach and in the previous study, so a bone marrow aspirates from the patients and the same bone graft. They were using here a myelomenous and non-myelomenous mice, and they were treated with saline or then bortezomib. So this was one of the drugs that I described in the earlier slides. So this is one of the drugs currently given as a standard of care to the patients. In panel A, we can see that patients with different stages of disease and whether they had an active bone disease or not were included. And if we have a look on what's happening to their BMD, we can concentrate on the grayish bars over here. So this is the mice before the treatment and with treatment of bortezomib. So here it doesn't see much difference. But when we look on the responders specifically, we can see that the ones that do respond to the treatment actually get an increase in their BMD, while there are some that did not respond to the treatment, and that's why they did not also see a response in increasing the BMD, and that's the reason why sort of the overall results goes hand in hand. Here they also provide information that how bortezomib treatment is affecting the tumor, because that's where its main indication is. And you can see here the white line reflecting the growth of the control tumors, whereas with bortezomib we can see that this line goes down, so meaning that the treatment is effectively affecting the multiple myeloma cell growth. And interestingly, the last point in the slide here is to show that they actually did visually also see how bortezomib can actually induce bone formation, and the mechanism of this I do not know, but the finding is really interesting when we are talking about mainly a cancer affecting compound. So in this case here, they did so nicely how the tumor burden longitudinally develops in the animal. So here it would have been really nice to see sort of as a second graph that how the BMD is developing in the animal models and how that goes hand in hand with the decreased tumor burden. Now we can head to the summary part. So I will give you a summary on comparison of preclinical and clinical on preclinical and clinical findings. So clinically, the multiple myeloma bone disease is really a major problem, and patients do suffer from really severe bone pain and increased risk of fractures, which you can probably acknowledge by the images that we went through in the presentation today. And as mentioned earlier, there is really no cure for multiple myeloma or multiple myeloma bone disease, so novel treatments are absolutely needed. And of course, in the best case scenario, there would be one treatment that can actually affect bone, the multiple myeloma, but also provide some help to the bone loss that the patients are suffering from. Well-established preclinical models can and they should mimic the important aspects of the multiple myeloma and the bone disease. And in the multiple myeloma animal models, you would wish to see tumor growth that is progressive, but that is also uniform between the different mice included in the study. And you would also see this bone loss compartment happening because that is really important when we are thinking about the disease overall. Lastly, it's really important that the models are tested against some reference items like bortezomib in the last example, and you can see those similar responses that are expected with the patient outcome. DEXA is a very powerful tool in multiple myeloma research, and I would personally think that it is especially useful for monitoring the in vivo bone loss in various different cancer indications. You can also do an individual and longitudinal monitoring of how the disease develops and how the treatment responses are observed within the animal models. As a third point, you can also sort of simultaneously, as you are looking at those bones, you can see also the effects on cancer-induced cachexia through analyzing the body composition. And this DEXA also provides a rapid and really easy to use method for analyzing bone, and it still provides this flexibility for the users to concentrate on their analysis on specific bones, for example. So for efficient translation, I think that it's really important that we are using the same imaging methods as a default in our preclinical studies that are used also in the clinics. Actually, this is something that the FDA, for example, have given a lot of attention nowadays, and that's bringing DEXA as a really interesting methods for different indications where bone is important besides the classical osteoporosis studies. And as the very last conclusion, maybe to put it in a different way, we know that mice are not men, but we can definitely make them to be more resembling of the human situation when we just consider on the most critical points. And I hope that I have been able to raise those in my presentation today. At this point, I have a question for Gabriel. So in regards of time, I have a few slides left here, but should we leave them to a different webinar since we have been talking quite a lot already on the myeloma aspect?
Hi, Tina. So thank you, first of all, for the great presentation. And maybe, yes, we can leave the topic for another webinar because we're running out of time, and I'm pretty sure the participants have some questions. So
Yes.
if you want, we can just jump into the Q&A section as we speak.
Yes,
So that's
let's
okay.
do that.
Perfect.
Thank you very much at this point from my side. So the last point would have been to talk about the cachexia in a bit more detail, but if there is interest, I'm happy to give another webinar and then we can dive into that into more detail.
That's perfect. Thank you so much, Tina, for the great presentation. And as we mentioned, we're now going to move on to the Q&A session where Dr. Jade Marrow, whom will be presenting at ORS, will be assisting us in addressing these questions. So at the moment, we have a couple of pre-submitted questions just to get the ball rolling and encourage everyone for asking any questions. We're going to go with the first one, which is, what are the best practices for longitudinal DEXA assessment in preclinical MM models?
So one of the important aspects here to consider would be then to include the baseline measurements in the studies that you are doing. So as mentioned in the presentation, there's a lot of variability between the bone measurements. So that is definitely one important aspect to consider when you are studying, in some case, the bone effects that what might be many quite minor. In regards of the longitudinal imaging, we have to remember that those bone changes, they are not really that acute or rapid. So you don't have to image your mice every day, for example, but usually if you do measurements once a week, then you would be able to see meaningful differences between the time points. So maybe those would be the two take-home messages from me.
Perfect. Thank you so much, Tina. Would you be able to do me one favor though? Would you be able to move to the next slide? If that's
Yes.
okay. Perfect. Thank you so much. Okay, so we have another couple questions. The next one is, could you comment on continuity of evaluation between different users?
Yes, absolutely. So DEXA is a very good method in a sense also that the the analysis itself is not affected that much by the users. So when you just have those images that I show you one example of the mouse here, so then the different users can use the same ROI boxes to analyze the different bones. One thing that is really important to consider and something that you cannot change before, I mean, after that study has been completed is positioning of the mice for imaging. So if you want to do really detailed analysis, like in the case of multiple myeloma in today's talk, you will have to make sure that the animals are always in the same position, usually the hind limbs, for example, stretched so that you can actually see the whole length of the bone. And that is something that should be a lot of attention based to that, because that will then also affect the results as you analyze them. But otherwise, I would still suggest that the same person can do the analysis itself, but there is really a minimum amount of sort of user-based error or differences in this front.
Perfect. Thank you so much for the concise answer. We're going to move on to the next question, which is, what is the benefit of DEXA in preclinical multimodal models? I'm sorry, not multimodal, um,
Yeah,
multiple
so
myeloma, sorry, models over the bone imaging techniques such as micro CT. There we go.
mhm. So I would think that the benefits of DEXA is especially that it is really quick and easy to do, but it is still really reliable and accurate method in when you are analyzing changes in bone and bone mineral density. So usually if people ask that what method they should select, then I usually advise that you could, for example, start with DEXA and then do your in-life measurements using the DEXA for the reasons that I just mentioned. And then you can, for example, concentrate on one specific bone and then do micro CD images, then ex vivo later that. So I think that that's really an efficient use of working time, and you will still get the same accuracy of results. And yeah, maybe that would be my recommendation. Jade, if you have something to add on that, let me know.
No, I think you summarized it quite excellently.
Yeah, thank you so much. Okay, so I'm going to give a couple moments just to encourage everyone to ask any questions. If not, we're going to be moving forward and ending the webinar. I'm just going to wait a couple seconds over here. Um, okay, then in this case, I'm going to proceed to ending the webinar. And first of all, I want to thank everyone for showing up today. And I would like to thank Tina for the excellent presentation and of course the viewers for attending this session. I hope that this session has provided you with a clear understanding of preclinical imaging of multiple myeloma bone disease. And as mentioned earlier, if you'll be attending ORS, please stop by our booth and have a chat with Dr. Marrow. If you have any questions in the coming days or weeks regarding the modalities that we discussed, please feel free to contact us at Scintica, and we will be more than happy to continue the conversation. Thank you all for taking the time to join us today, and we look forward to seeing you at a future Scintica event. Have a great day.